Hello, my name is Erin Allen, and I'm a certified athletic trainer. Today I'm going to present on human movement for injury in the basketball athlete. Basketball is a physically demanding sport and requires athletes to move efficiently and effectively to reduce injuries and perform at an optimal level. Areas that routinely display dysfunction that can lead to pain and/or future injuries are the first metatarsophalangeal joint, ankles, femoral acetabular joints, and the thoracic spine. Lack of motion within the distal joints will influence how the proximal joints move and vice versa, influencing the entire kinetic chain, creating compensation patterns that can increase the risk of sustaining athletic injuries. Joint dysfunction or compensation patterns are created by previous injuries, poor neuromuscular control or proprioception, tight musculature and surrounding connective tissue, and other various influences. Previous research has identified effective strategies that can be implemented to identify and correct faulty movement patterns and mitigate joint dysfunctions that, when implemented correctly, can reduce the risk of sustaining an athletic injury. Now, to begin with our four different body segments, we'll talk about the first metatarsophalangeal joint we'll discuss the dysfunction within that joint. So as we know, the foot is the terminal joint in the lower kinetic chain that makes contact with external resistance and accepts and imposes these forces during weight-bearing activity. When abnormal pronation and supination, which are hyper and hypomobilities within the foot and ankle, influence how the foot makes contact and can reduce the ability of the foot to absorb shock or toe off in running and walking gait. An excessive or restricted motion within the first MTP joint can be caused due to different foot types or postural deformities. One of the most common dysfunction or deformities of the great toe is hallux valgus. Hallux valgus manifests from ill-fitting shoes and intrinsic and extrinsic muscle imbalances. Hallux valgus reduces the ability of the great toe to press down during gait, and the great toe is twice as large and 4 times as strong as the other rays. So the inability of the first ray due to hallux valgus causes the metatarsal heads of 2 through 5 to be overloaded during these weight-bearing forces. Hallux rigidus is restricted motion within the first MTP joint and causes pain and stiffness at the base of the big toe. In early stages, it's referred to hallux limitus, which might be common in basketball athletes, which is when the range of motion of the first MTP joint is initially limited. Now, hallux rigidus and limitus involve the hallux lacking the ability to dorsiflex, which can result in gait compensation patterns and influence more proximal joint functions such as the hip. Forefoot varus is another common dysfunction, which results in the great toe and first metatarsal rising up in a non-weight-bearing position. The forefoot varus places the ankle in hyperpronation, which causes the tibia to internally rotate and further influencing the biomechanics of the lower extremity and creating compensation movement patterns. Now, there are different strategies to eliminate dysfunction and pain at the first MTP joint, which include utilizing orthotics such as a medial arch support or domed orthosis to improve symptoms associated with hallux valgus or metatarsalgia. Orthotics are beneficial to provide cushioning and plantar pressure distribution and limit motion across the joints, which is the most desirable in young athletes. The orthotic application is meant to correct the foot biomechanics to reduce the risk of future injuries. Also, selecting appropriate shoes for the athletes is essential. Choosing a shoe that fits properly on each foot is of utmost importance. Also, selecting a shoe that has a wider toe box that's more square is also beneficial to eliminating dysfunction at the first MTP joint. Providing joint mobilizations to the first MTP joint to improve mobility of the great toe is also recommended. Strengthening exercises that address the muscle imbalances, both intrinsic and extrinsic to the foot. So some strengthening exercises to consider would be great toe isometrics, toe curls for toe flexion, toe splaying, heel raising, and implementing gastroc and soleus stretching, with also aims at increasing great toe and plantar fascia extensibility. Implementing balance and proprioception training to improve the first MTP joint stability and intrinsic and extrinsic strengthening is also an advantageous strategy to eliminate dysfunction within this joint. There is also different taping techniques that are useful. Bunion taping or turf toe taping techniques are designed to facilitate the correct positioning of the hallux to be effective in stabilizing this joint and is utilized. It's most effective when utilized in conjunction with strengthening exercises and soft tissue stretching. When the intervention strategies are not utilized appropriately, or athletes and clinicians ignore dysfunction present within the first MTP joint, several injuries can manifest, causing pain and time loss from competition. Metatarsalgia can be caused from hallux valgus due to the inability of the great toe to flex as it pushes off the ground during the gait cycle. This causes the remaining metatarsal heads 2 through 5 to accept loads they are not meant to dissipate. Stress fractures are not uncommon in the second metatarsal when the first MTP joint does not dissipate forces correctly as a result of dysfunction. Hammer toe deformity can manifest when the plantar plate around the second MTP joint weakens and stretches as a result of force distributed from the great toe to the lesser metatarsal heads. Neuromas can also occur due to the altered kinetics and kinematics of the first MTP joint. There are connective tissue changes which occur and alter muscle function as well. So during walking and running gait, the great toe presses down into the ground, as we know, and provides a lever for push-off. But when the first metatarsal joint is restricted or produces excessive motion, the foot is unable to effectively absorb the forces and weight bearing, causing the forces to be distributed to more proximal joints, which results in Achilles tendonitis, medial tibial stress syndrome, plantar fasciitis, heel spurs, and knee pain. Now kind of moving our way up the lower extremity. Ankle sprains and lower extremity injuries can occur as a result of ankle dysfunction. Dysfunction can be displayed as instability or immobility. Two main types of instability are mechanical instability and functional instability. Now, mechanical instability is related to anatomical abnormalities within the ankle, which is usually related to ligament laxity or range of motion impairments of the tibiotarsal joint related to dorsiflexion range of motion deficits. Limitations within dorsiflexion is considered an influential factor in ankle instability. In fact, individuals with tight or shortened gastroc muscles reported ankle instability in 25% of patients in a recent research study. Ankle instability can result from previous injury, but not always. Hyperlaxity can exist within the ligament stabilizing the ankle, resulting in a lax or unstable ankle. And then functional instability includes the muscle structures and involves proprioception, or an element of posture control throughout movement. An example of functional instability may be hindfoot varus, which results in excessive pressure on the lateral edge of the foot, resulting in postural imbalances and single limb weight bearing. So the biomechanics of the ankle are a crucial component for normal functioning of the entire lower extremity. And abnormal mechanics of the foot and ankle causes a breakdown in the mechanics designed to distribute and dissipate these normal forces that occur during weight bearing. So when we have excessive or restricted motion within the ankle joint, it reduces the ability of the foot to act as a shock absorber. A torque converter doesn't allow the foot to adjust to the ground surfaces, and also inhibits the ability of the foot to push off during walking and running gait. When motion within the ankle joint changes, there's also connective tissue and muscle function that alters, which influences the distribution and movement patterns throughout the lower extremity. So when there's inadequate force distribution, it can lead to abnormal amounts of stress being placed on the joints, not designed to dissipate the applied stress, causing eventual breakdown and further injuries. And a clinician can assess for these range of motion restrictions within the ankle utilizing a weight-bearing lunge test to assist in determining the ankle's available dorsiflexion range of motion, and also help in deciding which strategies are best for correcting this dysfunction. So reduced ankle dorsiflexion range of motion and ankle dysfunction may occur as a result of tight calves, inherent ankle joint stiffness, or as a result of ankle sprains. And anterior cruciate ligament injuries and ankle sprains are most common ligamentous injuries in basketball athletes that occur with a non-contact mechanism and are associated with the presence of ankle dysfunction. Therefore, we must address these underlying factors that contribute to ankle dysfunction, which is instability or restricted mobility. So it's important to treat soft tissue limitations to reduce the range of motion restrictions or dysfunction that occur as a result of poor muscle extensibility. So some strategies to implement are foam rolling and stretching of the gastroc, soleus, hamstrings, quads, and overall lower extremity muscle is essential. Further, incorporating a dynamic warm-up that includes dynamic stretching is warranted. It was shown that basketball players who did not complete a general stretching program as part of their pregame warm-up were 2.6 times more likely to injure their ankle than a player who did include stretching in their dynamic warm-up. So increasing the plantar flexor extensibility and dorsiflexion range of motion is essential to ensure proper mechanics occur at the ankle joint. Also, preferring manual tibio-talar joint mobilization or mobilization with movement will improve the talar glide and ultimately talocrural dorsiflexion, which is necessary for athletes who have sustained chronic lateral ankle sprains or exhibit chronic ankle instability. Also, incorporating balance and proprioception training will improve an athlete's ability to stabilize oneself, which is another risk factor for sustaining a non-contact injury, and postural stability deficits during functional tasks also occur as a result of dysfunction or compensatory movements. So when performing proprioceptive activities, we can increase our ability to process information and execute motor commands more effectively. Implementing a balanced training program to improve balance and reduce the number of recurrent ankle sprains, and also helpful in reducing the risk of sustaining a non-contact ACL injury. So due to the influence of ankle dysfunction on proximal joints, it is essential to implement strategies that addresses specific ankle dysfunction in joints proximal and distal to the ankle. So implementing a strength training program that focuses on, in general, lower extremity strength and power, balance, proprioception, and overall improving the biomechanics have been shown to prevent lower extremity musculoskeletal injuries and are necessary to recover from movement dysfunctions. There is a significant relationship between hip abduction weakness on the involved side and chronic ankle sprains. Therefore, it's important to address glute med weakness and general hip abduction strength to reduce the risk of ankle sprains and further dysfunction at the ankle joint, and also provides us the availability to implement a comprehensive injury prevention program. Also, focusing on proper landing mechanics and movement patterns to ensure proper force absorption and ankle position occur during planned landings, which can also affirm proper movement patterns to be carried out during competition. It's important to correct faulty movement patterns as impairments resolve. When impairments resolve, this will help decrease the risk of future injuries and enhance athletic performance. Proper landing form and body movements decrease the abnormal pronation and supination within the ankle, the valgus stress at the knees, and adduction and internal rotation at the hips. Also decreases improper shock absorption and reduces the risk of non-contact injuries. Also, the strongest predictor of sustaining an ankle injury is a history of an ankle sprain. So, educating an athlete about the benefits of rehab following an initial ankle sprain to prevent further ankle or lower extremity injuries, and utilizing appropriate preventative measures such as taping and bracing to prevent ankle instability is important. And ensuring the athlete follows through with the rehabilitation program is imperative as well. Incorporating an effective injury prevention protocol is also beneficial. An example would be implementing the FIFA 11 Plus as a warm-up program, which is an efficient and effective in reducing injuries sustained in basketball and can help address poor movement patterns as a result of muscle imbalances, instability, or joint dysfunction. Now, restricted dorsiflexion range of motion may cause an increase in ACL loading and injury risk due to compensation patterns, which includes less knee flexion and greater knee valgus displacement and greater ground reaction forces when landing. When an athlete displays greater passive dorsiflexion range of motion, they experience greater knee flexion displacement and reduce the ground reaction forces, which are all risk factors for sustaining an ACL injury. Modified lower extremity movement patterns or compensation patterns result in forces being placed elsewhere, which contribute to an increase in the risk of ACL injuries and patellofemoral pain syndrome. Ankle dysfunction also, it places an athlete at risk of sustaining a patellar tendon injury. Also, dysfunction at the ankle joint or ankle instability places an athlete at risk of sustaining a lateral or high ankle sprain during basketball. Acute ankle sprains are known for their high occurrence rate, which is associated with the development of chronic ankle instability, further contributing to ankle dysfunction and poor movement patterns. Now, depending on the ankle dysfunction displayed by the athlete, the ability to appropriately dissipate weight-bearing forces will be hindered, which can cause inflammation developed within the foot and surrounding connective tissue, resulting in plantar fasciitis and Achilles tendonitis. In fact, reduced ankle dorsiflexion is a reported risk factor associated with patellar tendonitis, Achilles tendonitis, chronic ankle instability, metatarsal stress fractures, plantar fasciitis, and anterior knee pain. And when an athlete exhibits an inability to achieve appropriate dorsiflexion, the joint reduces its contribution to force absorption when landing from a jump, which increases the load on the patellar tendon and places the knee at risk again for patellar tendonitis and anterior knee pain. So it's essential to recognize the dysfunction and apply strategies to improve the dysfunction to the ankle to reduce the risk of sustaining athletic injuries and also improving functional performance. Now, moving further up the lower extremity, we're going to discuss femoral acetabular joint dysfunction. When the femoral acetabular joint displays range of motion limitations, the lack of motion influences stiffness within the sacroiliac joints, which further the lumbar spine due to responsibility of the sacroiliac joints to transfer load from the lower extremities to the trunk and vice versa. So this joint is very influential in connecting the lower extremity to the trunk and must dissipate the forces. So when there's dysfunction at this joint, it creates abnormal forces to be distributed and dissipated, which can contribute to how the SI joint functions and then the lumbar spine. So restrictions within the extensibility of the piriformis can lead to limitations within hip internal rotation, also causing a compressive force on the sciatic nerve. Femoral acetabular joint available range of motion is altered due to selective side dominance as well. So for instance, individuals who are right side dominant create an externally rotated and abducted left hip and an internally rotated and adducted right hip, with notable changes in the position of the pelvis as well, which influences the available range of motion within this joint and how the acetabular covers the femoral head. Additional research suggests that abnormal biomechanics at the femoral acetabular joint and dysfunction can create the presence of functional femoral acetabular impingement symptoms. When asymmetrical hip range of motion depends on the athlete's dominant side and can result in muscle imbalances, which further disrupt movement patterns and force absorption. So dysfunction within this joint affects strength, control, and mobility within the hips and can disrupt hip control and alter force distribution, which can cause articular cartilage, bone, or surrounding connective tissue degeneration as well. With poor hip control or weakness in the hip extensor groups, a flexed posture of the hip occurs and increases the internal rotation torque and potential throughout the hips. So lots can go on at this joint, resulting in dysfunction. There can also be dysfunction at the femoral acetabular joint due to bony structures of the joint, which results in greater adduction and internal rotation movements with the athlete when they perform a squat, which is a very functional movement. And athletes can display femoral acetabular impingement, whether it's symptomatic or asymptomatic, which exhibits weakness within the surrounding muscles, which further impairs the ability of the athlete to control their movements. So some strategies to address multiple dysfunctions at the femoral acetabular joint. Clinicians must establish motor control and proprioceptive awareness, utilizing neuromuscular training or exercise interventions that focus on increasing neuromuscular control. Additionally, increasing flexibility using stretching and manual release are beneficial in promoting an increase in range of motion and hip mobility. Restrictions within the piriformis can influence the availability of internal rotation within the hips, which can alter how the athlete moves. Additionally, previous research has found that a tight hip flexor, which restricts hip extension range of motion, is an identifiable risk factor for several lower extremity injuries and has been shown to decrease neural drive of the hip extensors. Hip flexor tightness can also affect lower extremity neuromuscular control. So utilizing a foam roller as a self-massage technique is efficient and effective method for increasing range of motion and functional performance. Utilizing mobilization techniques, mobilization with movement, and even self-mobilization techniques can aid in reducing hip mobility deficits and functional outcome. Core stability is an important component that should be added to the strength and conditioning programs due to the association between hip flexor tightness and local core weakness, which results in an anterior pelvic tilt causing muscle imbalances and dysfunction at the femoral acetabular joint. Incorporating interventions to address postural control helps eliminate dysfunction as well. Individuals that experience limited motion at this joint display significantly less glute max activation and a lower glute to hamstring ratio, indicating a need to incorporate glute and hamstring strengthening in the strength training programs to reduce the risk of injury. Implementing exercises to increase hip extension, range of motion, and glute strength have been shown to decrease the risk of sustaining hamstring and ACL injuries. Weakness within the hips that occurs in athletes with femoral acetabular impingement is important to restore muscle control and strength to provide stability. Incorporating some exercises such as the lateral step, sidestepping with the band has been shown to be influential in promoting hip abduction, glute medius strength, which is beneficial in reducing lower extremity injuries such as an ankle sprain. Additional interventions include single leg bridges, physio ball bridges, side planks, prone planks, alternating arm and leg lifts while stabilizing on a foam roller are good for glute and core stabilization. Also, research recommends closed chain exercises to also incorporating double and single leg squats, single leg RDLs, step ups, and lunges to improve strength and stability within the hips. Ensure all functional tasks are performed correctly as well to promote movement patterns and muscle activation and help carry the proper mechanics onto the court when performing sport-specific activities to optimize biomechanics. Then when these recommended strategies are not utilized to address femoral acetabular joint dysfunction, we place our athletes at risk of sustaining more additional musculoskeletal injuries, resulting in greater time loss from competition. There's a close association that's been found in restrained hip joints and the prevalence of non-contact ACL injuries. Athletes with decreased hip internal and external rotation have an increased risk of sustaining a non-contact ACL injury. Hip abduction and external rotation are essential elements in lower limb function. With reduced hip range of motion or hip dysfunction, the pelvic joints are considerably stiffer as well. Previous research reveals that low back pain is associated with range of motion limitations within this joint. Also, within joint dysfunction creates abnormal forces to be distributed and dissipated, which can contribute to how the SI joint functions in low back pain, and SI joint dysfunction can occur as a result of that. Internal rotation movement patterns within the hip joint also occur due to weakness present and associated with the pathomechanics of various musculoskeletal disorders, which can influence and cause patellofemoral knee pain in non-contact ACL injuries in active females. Due to the altered mechanics present within this hip joint, athletes are at risk of sustaining other lower extremity injuries, such as hamstring and adductor strains and ankle sprains. Hip flexor tightness can cause reduced neural drive and activation of the hip extensors, which causes the secondary extensors, the hamstring and the adductors, to produce hip extension torque greater than they're designed to do, resulting in injuries. The muscles surrounding the femoral acetabular joint can be weak or display muscle imbalances, which can contribute to femoral acetabular impingement syndrome. And the weakness and dysfunction within the joint is a contributing factor to sustaining all of these injuries. So individuals with femoral acetabular joint range of motion restriction and poor biomechanics result in an increased risk of sustaining future injuries, indicating the need to address any dysfunction initially presented within the hip joint, as it's a foundational structure that connects the lower extremity to the trunk and dissipates a lot of force. Now, the last segment we will discuss is dysfunction within the thoracic spine, and it has a great influence on how the shoulder girdle functions, in particular an athlete with excessive thoracic kyphosis, which causes the scapula to elevate and protract, which ultimately causes the shoulder girdle to be elevated and forward as well, and causes the glenohumeral joint to excessively internally rotate. So as you can see, it all goes together. And muscle imbalances and dysfunction occur within the thoracic spine as well, which influence how the scapula and GH joint accept excessive stresses, which can result in pain and injuries. So there are many other factors that cause dysfunction within the thoracic spine, which include inflammation, degenerative changes to the joint, scar tissue from surgeries or previous injuries, psychological stress, Restricted postures or mobility and breathing problems such as asthma can also influence the position of a rib cage and thoracic spine and function. Also, causing musculoskeletal imbalances in other areas of the body can influence how the thoracic spine moves. So, for instance, if the rhomboids and mid-traps, they're often chronically lengthened due to muscle imbalances, which reduces the ability to perform shoulder retraction properly and unable to effectively stabilize the scapula. Excessive rounding at the thoracic spine influences the position of the scapula and ultimately the glenohumeral joint alignment, which causes pain, inflammation, and injury within the shoulder girdle. So there are many strategies that we can utilize to address the dysfunction of the thoracic spine. So consistently and early activation of the transverse abdominis may reflect a feed-forward mechanism intended to stabilize the lumbopelvic region. So by increasing intra-abdominal pressure and increasing the tension of the thoracolumbar fascia, this can help this dysfunction. Some other strategies to address musculoskeletal imbalances and dysfunction within the thoracic spine: start with a dedicated program of corrective exercises, and implementing these exercises into injury prevention programs or strength and conditioning workouts is very advantageous. Utilizing specific movement techniques to improve muscle function and decrease the risk of injury. Utilizing self-myofascial release and manual techniques to the thoracic spine and shoulder girdle to address tightness within the rhomboids, the traps, lats, pecs, and rotator cuffs, as well as the erector spinae musculature, are all beneficial. Implementing stretches focused on thoracic extension and distraction, as well as rotation, are all recommended. In implementing pectoralis stretches as well help decrease mobility restrictions. Foam rolling is another advantageous strategy in releasing mobility restrictions and promoting thoracic extension to improve shoulder elevation and overall biomechanics. Thoracic rotation in a squat or kneeling, as shown here in the pictures, is advantageous to improving thoracic dysfunction and limited mobility. Implementing exercise modifications to improve muscle function and biomechanics is also beneficial when teaching appropriate movement patterns. So, for example, when an athlete is performing a deadlift, using dumbbells is helpful to allow the shoulders to externally rotate and depress the scapula and thoracic extension movement. Also, correcting movement patterns and ensuring the athlete performs each exercise with proper technique is important to reduce compensation. So tactile and verbal cues might be more necessary during this when addressing dysfunction at this joint. Incorporating exercises such as rowing and scapular retraction into strength training to strengthen the rhomboids and mid-traps are beneficial to also improve scapular stabilization. The goal is to improve posture stability and strengthening of the multifidi and erector spinae muscles are also important as they contribute to the forced closure of the mid-thoracic region. And implementing core stability and abdominal bracing previous to what I've mentioned is advantageous as it's shown to be one of the most effective exercise techniques to improve spinal stability. Using external support such as can be simpler strategies as they're easy treatments for the athletes to adhere to. So reducing kyphosis by utilizing taping or an orthosis have been beneficial. Therapeutic taping has in fact been shown to significantly reduce excessive thoracic kyphosis, which can be beneficial in addressing overall movement patterns if it's been really difficult for an athlete to do. So athletes can experience and suffer injuries as a result of thoracic spine dysfunction. Athletes with minimal kyphosis within the thoracic spine have been shown to be at a greater risk for quadricep injuries, which research believes to be due to biomechanical changes distally, such as the extensibility of the hamstring and quad to hamstring ratio or balance, which may explain this discovered risk from thoracic spine to quad injury. So when dysfunction is present at the thoracic spine and when that dysfunction is not addressed, especially in sports with repetitive overhead movements, the athlete may demonstrate symptoms of subacromial impingement as restrictions within the thoracic spine lead to poor mechanics of the scapula and ultimately narrowing the subacromial space, causing pain and inflammation. And an increase in thoracic kyphosis is correlated with an increase in low back pain, So when we ignore excessive flexion of the thoracic spine, we place our athletes at risk of sustaining low back pain due to the stresses placed on them during basketball and the inability to properly disperse the stress. Restrictions within the thoracic spine can also contribute to cervical pain due to poor mobility and poor posture, and rotator cuff tendonitis and other injuries as well within the shoulder joint. So overall, it's essential to address dysfunction throughout various body segments, as the dysfunction limits the athlete's ability to perform properly and causes the athlete to utilize compensation patterns to attempt to produce proper movements and performance. When the dysfunctions are ignored or ineffective strategies are utilized, our athletes are placed at greater risk of sustaining an injury and further time loss from competition. Therefore, we must address the underlying issues causing poor mechanics and compensation patterns. So thank you for your time and attention. Here's a list of the references I have used to complete this presentation. And please feel free to contact me if you have any questions. Thank you very much.